Hello, my name is Karen Brandon. I'm a clinical instructor and faculty at Loma Linda University in the physical therapy department, and I'm also a clinical educator for Loma Linda University Medical Center. Today's presentation is going to be introducing you to the role of pelvic physical therapy in the care of women in urology and gynecology to support their pelvic and female health. Our objectives for this talk are to share the primary causes of pelvic floor dysfunction and other musculoskeletal conditions and learn how to identify the symptoms. To introduce pelvic physical therapy practice principles and also to help provide tips and starting points for self-care for patients with bladder and bowel, pelvic pain, and sexual dysfunction complaints. So first of all, let's talk about physical therapy down there. What is that and who participates in this type of care? You have to first notice that women's health has expanded into many different areas of practice of medicine and different disciplines. Physical therapy for women's health includes taking care of patients with incontinence, overactive bladder, and prolapse, which is called urogynecology, sexual dysfunction and pain, inclusive of treatments for osteoporosis and lymphedema, as well as prenatal and postpartum conditions and musculoskeletal conditions in the pelvis. Typical physician or physician assistant nurse practitioner assessment workups for these types of problems oftentimes include a history and physical, labs and potentially imaging, and the differential diagnosis used to identify what's causing the problem are infection-focused, organ-focused, looking at different systems and how they interact, evaluating for unclear patient information or symptoms that coordinate and coincide, and really truthfully ruling out the big, bad, and ugly in terms of the scariest things that could be causing this problem. But if those have been assessed and identified, what else can be evaluated that might be contributing to this problem? The pelvic floor is a complex connection of layers of muscle, connective tissue, and other tissues that work reflexively, but then can become stretched, weakened, irritated, or restricted by many conditions. The pelvic floor muscles specifically are the functional contractile unit of the pelvic floor. They can be affected by injury, which could include traumatic injury or birthing trauma or any kind of surgical procedure. Infections, which even if the infection has resolved, could result in a reflexive pattern of tightening and guarding of the muscle groups, and also illnesses, long-term diseases. And oftentimes, while we think that everything is resolved and static, the pelvic floor muscles don't always spontaneously rehabilitate and go back to baseline. It's also important to note that they integrate and interact with the entire abdominal cavity and pelvic girdle into the hips. So, if you have a problem with your spine, it might impact the pressures and the integration of control at the pelvic floor. If you have an abdominal wall scar, that also might affect the pressures and the contraction and support of the pelvic floor. If you have pain in your hips, it may impact the ability for the pelvic floor to contract. And if you have instability in your joints of your pelvic girdle, the pubic symphysis or the sacroiliac joints, or even the tailbone, this could also throw off the ability of the pelvic floor to do its jobs. But what is normal? Oftentimes we have patients asking us, is it normal to go to the bathroom every hour? Is it normal to have difficulty emptying my bowel? Is it normal to have a little bit of discomfort with sex after I've had a baby? First, we need to understand all the roles of the pelvic floor, and there are many. One of them is to support the organs. So a lot of times patients have challenges after carrying a baby, after birthing a baby vaginally, also after doing heavy lifting, or if they have history of coughing, conditions or constipation. These things tend to strain or create pressure on the pelvic floor that needs to be intentionally restored. Also, obviously, the pelvic floor has holes in it, and those holes are controlled by the strength and the coordination of the pelvic floor muscles. So control, once we gain it after being potty trained, we know that we have the capacity to hold gas if we're in an elevator, but then if we're sitting on the toilet, we know that we can evacuate our bladder. So the ability to coordinate, knowing what those signals are, is also one of the roles of the pelvic floor. Core support. The support of the entire pelvic girdle when we're upright, standing and walking, or participating in activities like exercise or recreation. That ability to hold together, the glue, ends up being part of the pelvic floor job, as well as the abdominal wall and the strength of your ligaments in your pelvis. Sexual function. So while we sometimes think of sexual function as maybe being passive in some points and maybe active in other points, we know that the ability to participate is directly affected by tightening of the pelvic floor or by relaxation of the pelvic floor. And then circulation. These muscles, because they contract and relax consistently throughout our day, they tend to increase the circulation in that area. Now, what is pelvic floor dysfunction? This is a funny picture that illustrates the concept that everybody needs a very strong pelvic floor, which at some point can really be overdone. There are two main types of pelvic floor problems: underactive pelvic floor and overactive pelvic floor. In the underactive pelvic floor, these are typically things that we talk about in terms of weakness and inability to support our organs. So prolapse, which is the flexibility of the vaginal wall, either in the front or back or at the top of the vaginal vault, or leaking or loss. These are related to weakness or incoordination in an underactive pelvic floor. An overactive pelvic floor is it's less discussed, but it is definitely common in practice, and your gynecologist has the ability to assess for it as part of a possible pain complaint. So in pelvic floor overactivity, we notice that when the muscles are tensed, they're not able to move the blood flow. They are kind of Charlie horsed in some ways. It can lead to sensations of burning, difficulty with sitting, difficulty with penetration, whether it be a tampon or intercourse. It can lead to pain and difficulty with evacuating bowel or bladder, and also can ramp up your nervous system to give you more urgency and frequency in the absence of a UTI or after a UTI. Urinary retention or bowel retention because you're having difficulty having things pass through those openings. And also, when your muscle is tight, it can also be stiff. So if you were to jump or laugh, it doesn't allow a give that helps to keep everything in. It just stays tight. And so if the pressure is high enough, you could lose urine or bowel. So how does this all happen? Why and when does the pelvic floor become involved? It can be a traumatic or non-traumatic injury or surgery that occurs in the pelvic floor directly. It can be because of the incoordination between other areas of the pelvis. An example would be if you have a hip replacement. It's very common that they'll cut certain muscles that are attached to the hip when they replace it. And oftentimes we see an increase in urinary loss immediately after that might need to be intentionally rehabilitated to support the rest of the muscles that are intact. Also, we know that patients who have back pain significantly have an increase in pelvic floor tightness that actually causes pain there. So when your back is hurting, your abdominal wall oftentimes does not give you the support it needs. And therefore, a lot of pressure and a lot of requirement is on the pelvic floor. Sometimes after you have a condition or a disease process or an infection, then the aftermath is that the muscles in that area are stiff and tense almost protectively guarding because you had gone through what you'd gone through. And that could be a fibroid in your uterus. It could be a bowel issue like IBS, which might be chronic, endometriosis, interstitial cystitis. Anything that agitates your organs there oftentimes reflexively tenses your pelvic floor. And when and if these things are treated, it is still really important to evaluate if the pelvic floor went back to baseline or if it needs to be rehabilitated. And then there's incoordination of the pelvic floor. Sometimes because of a pre-existing problem, the pelvic floor doesn't do what it's supposed to do in different situations. So if you're sitting on the toilet and you felt a bowel urge and you feel the pressure, but you're unable to let the opening open, this can be an incoordination. So this happens often when we've had a history of hemorrhoids or any other trauma or problem in the area. So how do you find out if your pelvic floor is your problem? So first of all, if you have had recent changes in bowel, bladder, or sexual function, you should let your provider know if you've noticed the following things. If your vaginal area feels like there's a lot of pressure, or you notice a bulge by feeling it when you wipe at the toilet or when you're cleaning yourself, or if you can see it with a mirror. If you have an increase in urgency or frequency, or even difficulty emptying your bladder, and they've already checked and you've been negative for an infection or an infection has passed. If you have any leaking with activity or on your way to the bathroom. Some people think this is pretty normal if they've already had a baby or if they're getting older, but it's not normal, it's common, and it definitely can be addressed with the proper instructions first, and then an opportunity to evaluate and train your pelvic floor. And also if you've had pain with intercourse, whether it's entry or deep, whether it happens after or if it has always been that way. It's important to have your physician evaluate the tissue and also let you know about the status of the pelvic floor muscles. So if you happen to have abdominal pain, if you happen to have pelvic girdle pain, buttock pain, lateral hip pain, and you've been screened for orthopedic conditions, it's also important to notice that if your pain is worse with physical activity and exercise, if it's painful when you sit for long periods of time, if you're sitting or put pressure or touch a scar, either in your perineum or in your labia or by your tailbone or even on your abdomen, or if you're having pain worse when you finish peeing or during or after a bowel movement, these are identifiers that the pelvic floor could be tight or incoordinated, and you can ask your provider to evaluate for this condition. It's oftentimes that we're asked as pelvic physical therapists, aren't Kegels the panacea? Don't they take care of everything? Well, I'm here to tell you they're not. They don't take care of everything. They are incredibly valuable. I'm so thankful that God gave us the ability to squeeze our pelvic floor when we want to, not just reflexively, because that way we can train it and we can restore its function. But there are times when doing more Kegels can create a bigger problem. So if you ever squeeze to do your Kegel or your pelvic floor contraction and there's pain, if there's pain with sex and it hasn't been evaluated by a physician, if there's pain on any pelvic exam consistently, or if you have difficulty relaxing or releasing the muscle after a contraction, you may have overactive pelvic floor muscles, and it's worth discussing with your provider. So, what if you need to come to pelvic physical therapy? What needs to happen before you get there? It's really important that you follow up on all your regular checkups. Most of our checkups that are well women visits include a pelvic exam. But even if they didn't do a pelvic exam, if you are complaining of one of these things, before you get to pelvic physical therapy, it's important for your provider to rule out some of these conditions so that we can focus on mainly the muscle and the dysfunction that we can treat in PT. So make sure that you've identified and are in active process of treating UTIs, vaginal infections, pelvic organ prolapse has been identified and you've been given your options through our physicians. If you have hesitancy or retention, that's been further evaluated. Any medicine changes that might be increasing your bladder frequency or changing the way that you use your bowel or bladder. Any postpartum healing in that first 12 weeks, and any post-surgical healing in that first 6 weeks. All of these things need to be cleared. And then in the gynecological pelvic exam, they're also going to be looking for masses, rashes, discharge, any abnormal bleeding that's not around a period, and other causes of problems that might indicate the organs are involved. Now, it is possible to have comorbid or concurrent conditions, and as long as it's being managed by the physician, you can feel comfortable coming to physical therapy for the muscular component. It's also important that during the physical exam, your provider push on the pelvic floor muscles and see if that is direct reproduction of your pain. Sometimes it is, and sometimes the fact that it's tender, even if it doesn't reproduce your primary pain, is part of the problem. And they can also assess for your ability to squeeze and relax. So what does the pelvic PT initial evaluation include? We will also be taking your history and information about your current function and symptoms. Our focus is going to be on how it is affecting your life now and a lot of quantification of how often things happen in your daily life. We'll also be finding out about your job demands, your role in your life, and the type of environment you work or live in. We'll be doing an external anatomy assessment, looking at the position of your pelvis, the flexibility of your legs, your abdominal wall, if they have any scars, your ability to move your spine. We'll also be doing strength and coordination assessment to see if you have the ability to use your body in a way that supports all of the daily functions that you're doing. The internal assessment is going to be performed, if you consent, for the ability to evaluate your muscles for sensitivity, tenderness, tightness, and the ability to squeeze and relax. These are important in our ability to figure out where to start your care. And as needed, we use external or internal biofeedback to help track your ability to squeeze while you're doing different activities. And it shows you a readout on a screen so you can coordinate your ability with what you see on the screen. Pelvic physical therapy treatment is varied, and it will include many things depending on what's going on with you and your treatment plan. So it might include manual therapy, which is forms of massage, forms of stretching that are passive or partially passive. Most of those things we will be connecting with something that you can do yourself for self-care or with a partner so that you can continue that type of care at home. Neuromotor coordination training is what we call biofeedback, but it also can be relearning or retraining your muscles in how to move in different areas. Managing pressures. When patients have pain with upright activities, when there is prolapse, oftentimes we want to make sure that the thing they're doing for daily activity, whether it be work or recreation, is not increasing pressure into their pelvic floor. We'll be teaching you different ways to breathe and different ways to move. Dilator therapy. Sometimes an area in the pelvic floor, especially at the opening, requires specific and constant stretching. This might be with medical types of tools that you can place slightly internally into your vaginal vault and stretch per the instructions of the physical therapist. These will be homework, and then we'll work towards your ability to tolerate the use of a tampon or penetration. Functional training. So sometimes patients are very specific with what's creating a leak or what's creating pain. And if that's the case, oftentimes we use the neuromotor coordination training, but also brainstorming on adaptive ways to do things to avoid increasing pressure or pain. And then we'll be talking a lot about bowel and bladder self-care instructions. In all honesty, so many of us, when we're left alone after 5 years old in the bathroom, we really don't know what's normal and what's not normal. So retraining oftentimes includes a lot of anatomy and instructions in how the bladder and bowel actually work. So, you need a physical therapy referral, this is where you start. Our physical therapy program at Loma Linda University is run out of the outpatient physical therapy center at East Campus. It is very patient-driven. We need patients who are ready to take care of themselves with high motivation and commitment to home program, as well as showing up for their appointments. The visits are mostly weekly, and sometimes as you get better, they can extend to every other week. They're approximately 45 minutes. We know that many of our patients have more than one problem. In addition, it requires sometimes that they're getting disrobed, and we have to leave time for that and cleanup. Most of our conditions can be addressed and showing improvement by 4 visits. But to optimize and make sure that you can maintain the program, you might be seen between 6 and 12 visits, depending on what is happening. There are 2 specialty trained physical therapists here at East Campus, and we pride ourselves in the cleanliness and the beauty of our closed door treatment rooms for privacy of your care. Our program also extends and connects with our partners in different disciplines. We might be communicating with the person who sent you as a referral to the gastroenterology department, to the colorectal surgeon, to the urologist or the gynecologist, and their support team as well. Obviously, your care will include one of us, and we might even communicate with your primary care provider. We also have several support groups in the process of being started or already going that will address postpartum care, but also chronic pelvic pain. So where are some first-line steps, some things that you want to keep in mind from a pelvic physical therapist to you? I think it's really important to understand and maintain healthy bladder and bowel function. What does that actually mean? Fluid regulation. We want to make sure that you are ingesting enough water to make sure that you are flushing your bladder, but also that you are keeping your stool regular. We want to make sure that you understand sitting on the toilet for hours is not the way to get things out, and straining is never effective. Making sure that you listen to your bowel urge when it comes and follow it to the bathroom and spend time without straining to get the stool out is really important. If you're having challenges with this, make sure that you talk to your provider about it. Bladder urges can be tricky. At one point, we're told, don't listen to everything your bladder's telling you, but if you've ever had a very severe bladder urge, you know that it almost has to be obeyed, or else you could find yourself in a very embarrassing situation. So I would say that a healthy bladder is giving you an urge every 2 hours. If you're getting it more frequently on a regular basis and it's bothersome and interruptive in your lifestyle, you should talk to a provider. If you are waiting too long, and then you have accidents, that's an indicator that you are clearly waiting too long and you need to pay a little more attention. Also, we know that certain foods and certain drinks stimulate our kidney function to produce more urine and irritate our bladder lining. So we know that caffeinated beverages, carbonated beverages, certain types of sugar replacements, and spicy foods and also sour foods can increase our frequency or our urgency. So pay attention to how many of these you have in your system, and if you've looked at that, it might be maybe a new medication or worth a conversation with your physician. And then the idea of control. It is healthy to be able to maintain control. The ability to get to the bathroom is important, but there are so many things that can be in the way of that. Certainly, the ability to hold until you sit down is a healthy and normal function of bladder and bowel. So if you're having challenges with this, please first go back to the first 4 or 5 things and make sure that you're following and listening, and then have a conversation with your provider. One last thing. Our bowels are made to empty in a position that's very similar to a partial squat. not hovering over the toilet because that actually closes our openings, but the ability to relax in a bent knee, bent hip position. If you have challenges getting this position, there are other options, but if you're capable of putting a step stool or something underneath your legs, it will allow for a better opening of the pelvic outlet to improve your defecation. And it's really important not to hold your breath. So once you've been taught Kegels, you should be able to exercise routinely, almost like brushing your teeth. People say to me, how often do I have to do this? And I say, it's a maintenance plan. You have to do it because it keeps you healthy. So this prescription for Kegels has changed many, many times throughout the years. But the basics still exist that if you're capable of doing 5-second contractions 10 times, approximately 4 times a day, that's what we need for maintenance. What we need for improvement is greater, at least 10 seconds if you're capable of holding for about 10 times, about 7 times a day. Now, if this sounds challenging, please recognize that what you put into it is what you get out of it. And if you're having challenges with motivation or wondering if you're doing it correctly or pain, make sure that you talk to your provider. Some of the cues that are often used to help people figure out how to turn on their pelvic floor correctly are things like pull your tissue up and in, shy vagina, shy anus, tuck the clitoris and pull it up and in, and maybe zip up the vaginal jeans. Everybody is different. Just like a teacher in a classroom, we all have to figure out what cue works for you. So hopefully one of these will actually produce the results we want. It's most important that if you get an opportunity to be with a provider and you would like them to check it, then just let them know, and they'll evaluate what they see and what they feel, just to make sure that you feel confident with what you're practicing at home. Another important thing is to keep your hips and spine flexible. Why? Because all of that pressure will go down to the pelvic floor, and the pelvic floor will have a greater demand. It may even become overactive because of the lack of use of the other joints. In addition, our core is the coordinator with our pelvic floor. So that means keeping our core strong, not necessarily with sit-ups, but things that actually draw our navel in. These things will help to support the entire canister of air so that the bottom doesn't have to do so much work. It's important to recognize that if you already know you have a hip problem, a knee problem, a spine problem, that you work with your providers, whether it be your orthopedic physician, whether it be your orthopedic physical therapist, your primary care physician, to come up with a way that you can work around that so you can optimize your health and it doesn't become a bigger problem for your pelvic floor. It's imperative that we talk about good sleep habits. If you understand that the pelvic floor is connected to everything, it also needs rest. It needs rest and it needs to be able to come down from tension and stress. So keeping up on good sleep and cardiovascular exercise will keep the circulation going well there. It'll also keep stress levels down and it'll help your body recuperate throughout the night. In addition, the support of our body in standing and sitting and sleeping is also valuable. Things that are strained over time because of poor support, whether it be sitting with bad back support or sleeping with our legs or our spine in an abnormal position, can start to create problems in the pelvis that trickle down to the pelvic floor. So in summary, the things I want you to remember are: look, listen, and ask about any changes you experience to your bowel, bladder, incontinence, sexual functioning, and pelvic pain. Remember, a healthy pelvic floor is both strong and flexible, and it has a lot of jobs. If you're having a pelvic exam, ask the provider to check the muscles. Pelvic physical therapy can be the first-line treatment option for bowel and bladder incontinence, pelvic and sexual pain, and be very successful in teaching you lifelong skills to take care of yourself. One more thing, the healing is not in the medicine, but it's in the patient's body, in the recuperative and self-corrective energy of nature. Take care of yourself and your pelvic floor. Thank you.